The Keynote 189 trial was very important and immediately impacting our practice. This trial was presented in the plenary session at AACR 2018 and published in the New England Journal at the same time, reflecting its importance. And it was a randomized phase 3 study of just over 600 patients with advanced non-squamous non-small cell lung cancer who were randomized to receive either chemotherapy, which was cisplatin or carboplatin and pemetrexed alone or with placebo, or with pembrolizumab. The patients could have any degree of PD-L1 expression from negative or less than 1% to high level, more than 50%. And we had already known from a press release before the presentation and publication that it was positive for overall survival, but we didn't really know how positive. And the answer was tremendously so, with a hazard ratio of 0.49 in overall survival, which is really impressive for a trial in advanced non-small cell. Importantly, we also needed to clarify whether patients, not just with high-level PD-L1 expression, but even with lower levels, say 1 to 49% tumor PD-L1, or even negative, got a benefit from concurrent first-line chemo and pembrolizumab? And the answer was yes, there was. It was greatest in the patients with the highest level of PD-L1 expression, but it was still clinically significant and statistically significant when broken down into those other subgroups of low level 1 to 49% or even negative. And that was the case when we're looking at endpoints of overall survival, progression-free survival, and also looking at response rate. Toxicities were nothing really unexpected, a little more of the immune-mediated side effects that you'd expect, but basically a superimposition of what we've come to experience with the immune checkpoint inhibitors and Pembro in particular, as well as the chemo regimens. So this is something that is going to change practice. We already have an FDA approval for carbo, pemetrexed, and pembrolizumab in the first-line setting based on the Keynote 21G trial, which was a randomized phase 2 with 123 patients. So though we had the option available to us, it has not been broadly adopted by thoracic oncology specialists or general oncologists as much because we were waiting to see bigger results. We have that here, and it has been as much of a difference as we could ever expect or hope to see. The Keynote 189 trial is definitely changing practice right now, and I expect are going to see evolution of treatment recommendations as reflected by the NCCN guidelines and others. I think it will be interesting to see what should be a breakdown by whether patients have high-level PD-L1, lower-level PD-L1, or negative PD-L1, because in each of these settings, we are likely to not just have the Keynote 189 trial results, but we already have Keynote 024, which is Pembro versus doublet chemotherapy, Pembro as a monotherapy. And we also are going to soon be considering the results of the Keynote 042 trial, which look at Pembro monotherapy versus chemo doublet in not just non-squamous, but squamous as well. And that's in a broader population of patients with any degree of PD-L1 expression as well, so of 1% in Keynote 042. So in the patients with non-squamous, non-small cell, and high PD-L1 expression, we will see that pembrolizumab monotherapy remains an option. The efficacy is a little bit higher with chemo and concurrent pembrolizumab, so I believe both will be considered as favored options to consider, with it really being left to judgment of the treating physician and the individual situation as well as the patient about whether to go for monotherapy versus a triplet with chemo and immunotherapy. And I think that soon we will see that extend to the patients with 1% as the cutoff for PD-L1 based on the combination of the KEYNOTE-189 trial and the KEYNOTE-042 trial results. So we're going to see all of these options, or both of these options, of chemoimmunotherapy versus monotherapy, depending on the situation and physician judgment. And in the patients without PD-L1 expression, we will see a growing trend toward greater use of the combination of, at least in non-squamous non-small cell, probably much more carbo with pemetrexed and pembrolizumab, given that we already have that approval. CIS will likely be included as well based on the KEYNOTE-189 trial. But I will mention that they did have more renal toxicity in KEYNOTE-189, and so that combination may be one that I would be less inclined to do cisplatin for. And at the same time, in a broader setting, we're going to have other trial results with chemoimmunotherapy with agents like atezolizumab as a potential option in the coming months. So what I would envision is that the NCCN guidelines are going to be revised many more times in 2018 and beyond to reflect a growing number of options. But I think that chemo and immunotherapy with pembrolizumab is going to be high on that list.